today's webinar, so this should be posted on our YouTube channel, and we will also be making our slides available for you to look at after the presentation. Before I get started, I did want to point out that nothing that we share with you is intended to be prescriptive or legally binding. This is a presentation based on a synthesis of information that is available publicly as well as best practices. Just so you don't get confused, if you do send me a chat request, I'm using Megan's ID, so don't let that confuse you. So meaningful use, as you probably know, is a set of standards that the CMS defined to encourage providers to use electronic health records. It's a program that is based on financial incentives, and the intention is for providers to use this certified EHR technology in a manner that is meaningful, to be able to exchange health information as well as to submit clinical quality measures. There are 3 stages of meaningful use as the program stands today. Meaningful use stage 1 was designed with the purpose of starting to collect information from EHR systems. Meaningful use stage 2, which went into effect earlier this year, is designed to improve the exchange of information. And then stage 3 is designed to focus on improving outcomes. So if you happen to be a more visual person, this is a graphical representation of what the 3 stages are. And depending on when you started participation in the program, you will either be in stage 1 or stage 2. Stage 3, the criteria for stage 3 has not been made available yet, and the expectation is that this should be available sometime in fall of this year. So initially, this has changed, and that's why I wanted to share this with you, because initially meaningful use stage 1 was supposed to be 2 years, stage 2 was supposed to be 2 years, and then stage 3. But now, with the proposed rule, if it does go into effect, providers could actually end up being on testing for stage 1 for 3 years. So the proposed rule, which has been filed under the code CMS 0052P, and I'm sharing the code with you because my hope is that this might serve as a call to action and that you might want to submit a public comment. And so I wanted to provide you with all the information that you would need to be able to do so. So the proposed rule is designed to change the meaningful use stage timeline and the definition of certified electronic health record technology, or CEHRT, as well as the requirements for the reporting of clinical quality measures for 2014. Eligible professionals who have not been able to fully implement the 2014 edition EHR system for the full EHR reporting period in 2014 would be allowed to continue using the 2011 edition. If you have been participating in our webinars, you might recall my mentioning that the 2011 certification actually sunset at the end of December 2013. However, under the proposed rule, CMS would allow healthcare organizations that have not been able to implement the 2014 edition to attest using the 2011 edition. Or healthcare organizations would be given the option of combining the 2011 and 2014 technology for EHR reporting periods in calendar year or fiscal year 2014. This change is for 2014 only. All providers are required to use the 2014 edition certification for fiscal year and calendar year 2015 and beyond. It's important to remember that Medicare attestation and Medicaid attestation follow different calendars. Medicare, hospitals and eligible providers follow different calendars. Hospitals follow the fiscal year, which begins in October, and eligible professionals follow the calendar year. So if this EHR edition that is available to a provider, let me back up. The addition of the EHR that is available to the provider will dictate what stage and version of the meaningful use criteria the provider can attest for. So if a provider is using 2011 criteria, 2011 certified EHR, then they would attest to the 2013 criteria for meaningful use stage 1. And this is even if the provider was otherwise eligible to attest for meaningful use stage 2 in 2014. The CQMs, if the 2011 edition is being used, will be from a set of 44 measures per meaningful use 1 criteria, and I'll go over the criteria later in the presentation. Providers can also, would also have the option of using a combination of 2011 and 2014 edition EHR, and they would then have the option of reporting on the 2013 meaningful use 1 criteria or the 2014 meaningful use 1 criteria, if they're otherwise eligible for meaningful use 2. In this instance, providers need to attest that the EHR technology, the 2014 edition EHR technology was delayed. And if attesting under this option, the CQMs would be the same as the 2013 criteria if the provider is using the 2011 edition. And if the provider is using the 2014 edition, then the 2014 CQM criteria will apply. Providers can, who are scheduled to begin meaningful use attestation in 2014 but are unable to fully implement all functions of their 2014 edition because of delays in its availability, would be allowed to use the 2014 edition EHR to attest for meaningful use 1 or 2 2014 criteria using CQMs based on whether they're testing for stage 1 or stage 2, but for 2014. And they would also be required to provide attestation about the delay. So what can you do? As you've probably realized, even though I tried really hard to simplify the language of the proposed rule, it is extremely ambiguous. And so the hope is that you might want to make your voice heard. And so there is a 60-day public comment period that began on May 23rd, which was the day that this proposed rule was published in the Federal Register. And if you didn't actually write the file number, you can either Google it or feel free to send me an email afterwards, and I can send you the file reference number. And so you have a few different options. I'm sorry, I think I might have skipped over a slide. Nope, sorry. Okay, so you can either submit your comment electronically, and the website for that is www.regulations.gov, or you can send in your comment by regular mail. I don't expect you to copy this, but if this is something you're interested in, email me afterwards and I'll be happy to send you this information. You can also send information by, you can hand deliver it, send it by courier, or you can also send it by overnight express mail. So one of the main reasons why organizations have been rushing to change their health information technology roadmaps was to meet ICD-10 implementation and then also meet meaningful use for 2014. However, as we know, that ICD-10 has been pushed back, they say, for at least a year. So the new start date for ICD-10 is projected to be October 1st, 2015. And now if this proposed rule does go into effect, what this would mean is that you are no longer in a time crunch to upgrade your EHR. So what you should do is, first of all, I would recommend that if there is any aspect of this proposed rule that you feel warrants comment, that you do submit a comment. If you have been following this in the news, you probably have realized that this proposed rule is very ambiguously stated, and it's caused a lot of consternation amongst healthcare organizations that are charged with having to correctly interpret the rule. So the proposed rule does not provide guidelines for attesting that the certified EHR technology was not certified in time. There needs to be greater clarity on the requirements for organizations to attest that their EHR application was not certified within a well-defined time period. Moreover, there's ambiguity around whether an application that was otherwise certified but relies on components such as HIS and other reporting tools that are not yet certified under the 2014 edition qualifies for an exemption under the proposed rule. Even complete and non-modular EHR technology relies on additional components for tracking and reporting on clinical quality measures, or CQMs. In some instances, the core EHR application has been certified under the 2014 edition criteria, but its complementary reporting tool has not. How does the proposed rule affect attestation for organizations that have implemented partially certified technology? There isn't any clarity around that in the proposed rule. And then finally, the verbiage of the proposed rule does not explicitly state whether it also affects Medicare Advantage organizations. So if your practice happens to be a Medicare Advantage organization, historically, MAOs have followed somewhat different reporting methodologies for MU attestation. But there is no mention in the proposed rule about whether MAOs also have the flexibility to attest for meaningful use, even if their EHR technology is not fully certified under the 2014 criteria. We recommend that you do still move forward with your plans for meaningful use too, to minimize risk. This is, after all, a proposed rule, and even though historically proposed rules have gone into effect, especially when it means providing more lenient guidelines, as we've seen with ICD-10, you still don't want to be caught off guard. So you should probably continue to move forward with your efforts. Then it would also behoove your organization to confirm with your EHR vendor whether a hardship exemption will be possible. So if your vendor is fully certified under the 2014 edition and all components are fully certified, then your practice would be hard-pressed to claim any kind of a hardship. You should also run your Meaningful Use 1 and Meaningful Use 2 reports to assess your readiness for attestation and determine whether you need to, what period you will be reporting for. As you know, for hospitals and for Medicare, you have to report for a calendar quarter. this year, whereas for Medicaid, you can choose any 90-day period. If you haven't yet, if your providers haven't yet met meaningful use for this year, you might want to have them really step it up in the July to September quarter so that if the proposed rule doesn't go through, you are able to fill a test. And then most importantly, you need to estimate what the financial impact of attestation is. So a couple of things to consider here are that with Medicare, Medicare requires that attestation be done every year from the time you first started testing. So there's a sequential file attestation rule. And if you don't attest in a given year, you basically forfeit any reimbursement you might have otherwise got that year. Medicaid, on the other hand, is a little bit more forgiving, and it does actually allow you to skip a year, but you can make it up. So you would still end up participating for 6 years if you began participation in 2011 or 2012, but you wouldn't get any reimbursement for the year that you skip. However, there's no penalty. With Medicare, you also need to factor in whether your practice would be impose any kind of a payment adjustment or a penalty, because that could drive your decision around whether it makes sense for you to skip a year of attestation or not. So let's talk about what the Meaningful Use 1 criteria is. They're basically 13 core objectives for hospitals and critical access hospitals, and 14 measures for eligible professionals. Core objectives must be met in their entirety, which means that whatever thresholds have been established, the providers must meet all those thresholds, meet or exceed. And then there are a total of 10 menu objectives, of which 5 must be selected for stage 1. And clinical quality measures need to be reported. There are 15 for hospitals and critical access hospitals, and there are 6 or 9 for eligible professionals, depending on how the provider's clinical quality measures turn out. So I'll talk a little bit more about that in a few minutes. So the Core 1 objectives, the first one is computerized provider order entry. And what this is making sure that there is at least one medication that is ordered through your EHR, and the threshold for this is 30%. The drug and drug allergy check, this is the system configuration that needs to be enabled. You would, at the time of attestation, this would be a yes or no question, and you would want to provide a screenshot of your system configuration to demonstrate that this functionality was in fact enabled. Maintain an up-to-date problem list of current and active diagnoses. The threshold for this is 80%. E-prescribing, the threshold is 40%. Maintain active medication list. This is basically all the medications that the patient is actively using, and the threshold for this is pretty high, 80%. And maintain active medication allergy list. The threshold is 80% for that as well. Record demographics. So the threshold for this is 50%, and there are 5 pieces of information that the CMS wants you to capture: preferred language, gender, race, ethnicity, and date of birth. Of course, we can argue whether race and ethnicity are the same or not, but this is not an anthropological class. So, but those are the 5 pieces of information that are required to be captured. And then 50% of patients' records need to have changes in vital signs. Patients who are 13 or older their smoking status needs to be recorded, and threshold for this is 50%. The next one, implement clinical decision support. The requirement is that you need to demonstrate that you had at least one clinical decision support enabled. Again, at the time of attestation, this would be a yes or no question, and you would be required to describe which clinical decision support was enabled. For those of you who are on NextGen, there are lots of different decision support rules that are built into the system, as are for all other EHRs as well. So, for example, if your EHR system supports protocols or care guidelines, or if it gives you an alert if a patient's vitals are out of range, all of those would be examples of clinical decision support. However, it's important to remember that drug and drug allergy functionality cannot be considered to meet this particular measure. Even though that is a clinical decision support rule, it is in addition to this measure. And then provide patients with an electronic copy of their health information upon request within 4 days. And so this is where a patient asks for release of information in an electronic format. Providers are required to provide clinical summaries for patients for each office visit within 3 days. And then protect electronic health information. The threshold for this is 50%. The menu objectives. So these menu objectives, there is a choice. There are a total of 10 menu objectives, and you can select 5. However, it's important to remember that all 5 menu objectives have to be the same for all the providers in your practice. So you can't have drug formulary for one and incorporate clinical lab test results for another. They have to be the same. Drug formulary checks are, again, a system configuration question. It's a yes or no question, and you need to demonstrate that you had enabled this functionality. Incorporate clinical lab test results. This is if you have a bidirectional interface, or at least a unidirectional interface with the lab where the results are coming back to you. Then use your EHR to generate a list of patients by specific conditions. This is something where if your practice has already transformed into a PCMH or is in the process of transformation, these reports and lists are going to be very actively required for PCMH population management and other kinds of population management. Send reminders to patients for preventive follow-up care. So this is really important because there is a fine print with this particular measure, and that is that the patients need to be younger than 5 or older than 65. So this is not across the board. Patient-specific education resources. There's sometimes confusion around this measure because providers aren't sure whether these education resources need to come from your EHR. But at least for stage 1, as long as you're documenting that some educational material was given to the patient, it does not necessarily need to be generated from within your EHR. Medication reconciliation for transition of care. This is a tricky one because unless a practice understands what transition of care is, the chances are that this will not be documented correctly. So transition of care is defined as a patient coming back into the care of a provider at your practice, either after being discharged from the hospital or the emergency department, or a new patient. So there is, in all EHR applications, there is a a separate, whether it's a checkbox, whether it's a radio button, but there is a way to distinguish whether a particular patient or particular medication reconciliation was performed specifically for transition of care. And more often than not, a lot of providers actually forget to check that little checkbox or select that option, and so their performance ends up getting skewed. Summary of care record for transitions of care. So this is the inverse of transition into care. And what this is if a patient has been referred out to a specialist or is transitioning out of care of your clinic to another practice, then you're required to provide a summary of the care that was provided to the patient in your practice. Electronic access to health information, so this implies the need for a patient portal. And then the last, there are two different menu objectives, and you're required to select at least one or at least one. So you either need to submit electronic data to your state immunization registry, or you need to submit electronic syndromic surveillance data to public health agencies. So people sometimes get confused about what syndromic surveillance is. This is something that is actually already being done in all practices, and this would be anything that is any disease, communicable disease that is reportable. So let's say it was, a patient comes in with suspected tuberculosis, or H1N1, or any of the other viruses that need to be reported. That's what syndromic surveillance data is. And you are required to perform at least one test to demonstrate that your EHR is capable of meeting this requirement. Now, clinical quality measures are actually really interesting because, first of all, there are no thresholds. You basically report the clinical quality measure as is. You're not required to do any calculations of numerator and denominator, and these can vary by a provider. So not all providers are required to report on the same measures. As I mentioned earlier, you need to select 6 or 9. So 6 of possible 44. 3 are required, and then 3 are alternate core. And then you're also required, if you don't meet the 3 required, like if your providers have 0 numerator and 0 denominator for the 3 required core, then you're expected to select 3 additional, hence the 6 or 9. And reporting for clinical quality measures is done through attestation, and there are electronic reporting pilots. It's been combined with PQRS and other portals such as QualityNet for hospitals and critical access hospitals. So what's the difference between the 2013 and the 2014 Meaningful Use 1 criteria? The most important difference is that exclusions for menu objectives have been discontinued in the 2014 criteria. Under the 2013 criteria, if you said that, let's say your local public health office does not have the capability to accept an electronic syndromic surveillance report, you would be excluded from that measure, but it would count toward you actually meeting that measure. So that exclusion has been taken away from the 2014 criteria. For computerized provider order entry, there is now an alternate measure. And in the 2013 criteria, CPOE attestation required the total number of unique patients. However, in the 2014 criteria, this is the total number of medications as opposed to the total number of unique patients. E-prescribing, there's an exclusion that's been added for 2014 that is based on geography. If a pharmacy within a 10-mile radius of where the provider is e-prescribing does not have the capability to accept e-prescriptions, that can be excluded, and it would count as toward you meeting that measure. So there are also age and practice-based exclusions for recording and charting changes in vital signs. It used to be that patients older than 2 had to have their vital signs recorded. That has now been adjusted upward to 3. And then if a provider believes that recording vitals at every visit is not optimal for the particular practice, then that can be excluded. And an example of this would be, where you have a dentist, for example, who really doesn't need to record vital signs, as it doesn't drive any clinical decisions for patients to go to see a dentist. There used to be electronic exchange of key clinical information that's been discontinued for Meaningful Use 1. The CQMs no longer need to be reported as a separate objective. The electronic copy and electronic access to health information, for 2014, the availability for both is 4 business days. And public health reporting, you could skip both of these menu objectives in the past, but now you're required to test capability for at least 1. So let's talk about Meaningful Use Stage 2 now. This has gotten a little bit tricky because initially the intention was that Meaningful Use providers would be attesting for Stage 1 for 2 years. But now this is going to, if this proposed rule goes through, this will now change to 2 or 3 years. The focus of Stage 2, as I alluded to earlier, is on advanced clinical procedures, so that there's a better emphasis on health information exchange. You've probably been hearing the acronym HIE, and what that essentially is, being able to exchange information not within your own practice, but across practices and healthcare systems as well. There is enhanced e-prescribing and lab result requirements for Stage 2, and I will go over those with you. There's continuity of care across multiple settings, and this is starting to now sort of tie in a little bit with where PCMH is headed. And then, of course, there's increased patient and family engagement, which also is a core precept of PCMH. The ultimate objective is that by implementing all these measures, patient care will improve. So the core objectives for Meaningful Use 2, computerized provider order entry. This is the same, but if you notice, the threshold has doubled. It's and not only has it doubled for medications, but it's also expanded to include laboratory and radiology orders, which is something new. And so if you haven't already started thinking about a lab interface and a radiology interface, you might want to start putting that on your radar, because for Meaningful Use Stage 2, that is going to be required. The threshold for e-prescribing has gone up. The demographics has gone up. The 5 pieces of information remain the same. To record vital signs, smoking status, those are all the same. Clinical decision support. So this, if you remember, in Stage 1, you were required to demonstrate just 1 in addition to drug formulary and drug-drug and drug allergy interaction. Now you're required to demonstrate 5 different clinical decision interventions, and these need to relate to at least 4 CQMs. So now you're starting to see this shift in using your EHR data to start driving health outcomes, which is really the ultimate objective of this program. This is the piece that is causing people the most grief. Provide patients the ability to view, download, and transmit their health information electronically. So what this requires is the implementation of a patient portal. And this is a two-part measure because, firstly, you need to have at least 50% of your patient population enrolled in your for access to your portal, and of that, and 5% of your total patient population needs to be actively using the portal. And so active use is described as being able to schedule appointments, being able to request refills, and being able to exchange secure messages with providers. Clinical summaries for patients for each office visit, this is still at 50%, but it's gone from 3 days to 24 hours. Protect electronic health information. So this is, for stage 1, healthcare organizations were required to do a security risk self-assessment to see how secure their environment was for protecting patient information. For this stage, the language is a little bit vague, but basically you either need to do another follow-up risk analysis, especially if you had identified some gaps in your self-assessment, or you need to actually hire a vendor who's certified by your state to perform this kind of risk analysis. The language is, like I said, a little bit vague, so it might be better for you to err on the side of having a state-approved entity do your risk analysis. Incorporate clinical lab test results. So you've noticed that this has jumped up from 40 to 55%. The list of patients remains the same, but now it's moved from a menu objective to a core objective. Identify patients who should receive reminders for preventive follow-up care. So the criteria for this has changed a little bit. 10% of unique patients with at least 2 visits in the 2 years preceding the reporting period. Identify patient-specific resources and provide to patients. So this is where you now start getting into being able to use your EHR to identify educational resources that can be given to patients. Perform medication reconciliation. This was previously specific to transition of care, but now it applies to all your patients. And provide summary of care record for each transition of care or referral. And this is where if your practice ends up becoming a part of a health information exchange system, it would make life so much easier because you wouldn't actually need to provide this, the provider that you're referring out to could just pull this information directly from your EHR. Submit electronic data to immunization registry. So this is now evolved from just doing one test to actually successful ongoing submission. And then use electronic messaging to communicate with patients. 5%, I already talked about this earlier. So again, with the syndromic surveillance, now it's shifted to successful ongoing submission. This one, the next one is such a it's almost like a giveaway because every provider who is using an EHR does record notes in a patient chart. And so if you need an easy menu objective to report on, this would definitely be one. Imaging results. so I mentioned earlier that this might be a good time for you to start thinking about whether you want to have an imaging interface or not, because it is entirely possible that with stage 3, this may become a core objective. Record patient family health history. So this pertains to first-degree relatives, so that would be a mother, father, a sibling, or a child. Report cancer cases to a public health central cancer registry, and again, this is now moved past the stage of just doing a one-time test, but it actually is successful ongoing submission, and then also being able to report specific cases to specialized registries. And this, again, it's a bit vague, so you would need to find out what specific cases can be reported and what registries to report them to. So selecting CQMs in stage 2, the recommendation is that you select a core of 9 of possible 64 CQMs. And so CMS has actually created this core set of 9 measures for adult patients, and then another set of 9 measures for pediatric patients. And if your practice were to decide to not use these core measures, even though that's what CMS is recommending, then you have the National Quality Strategy domains. There's 6 of them, and you are required to choose your CQMs from at least 3 domains. All right, so that was what I wanted to talk about. If you have any follow-up questions, you can either email Dan or you can email me, and I'll be happy to get back to you with answers. So I have a bunch of questions that I'm going to try and address one at a time. Well, the first question, I'm afraid I don't really have a context for it. It says, is it possible to give us an example of what you're talking about? So I'm not really sure what that question pertains to. Is the proposed delay for Medicare only? No. If this proposed rule does go through, it will be for both Medicare and Medicaid. What we don't know for sure is whether this will also impact Medicare Advantage. That's a big question mark for now. If a provider is on stage, okay, let me read this. If a provider is on stage to meaningful use this year, can they use the 2011 edition and attest to stage 2? Okay, so your question is vaguely worded. I'm not quite sure what you were wanting to ask. You might have forgotten to, yeah. So whoever asked me this question, can you please rephrase it so I can understand what you're trying to ask? We are on the Medicaid track, and we are currently on the 2014 CEHRT, but to be ready to attest for stage 2, we need the patient portal. Yep. And the direct protocol interface. Can we claim the hardship exception because we will be implementing them? No. Unfortunately, you can't claim a hardship exemption because you didn't implement something on time. The only way you would be able to claim a hardship exemption would be if your vendor was not able to, if the vendor's product had not been certified. Your own planning process does not constitute hardship. What is considered a medium for submitting syndromic surveillance? Yeah, so you're a public health agency, but you don't have NextGen set up to receive electronic data, which means that all practices that would typically want to send you syndromic surveillance electronically will not be able to do it. So to answer your question, the medium is electronic submission. We would like to know what is meant by accessible imaging. Incorporating PACS images would mean a hospital-sized image store. Can there be a link 2 outside hospital PACS system, yes. So basically, the requirement is not for your EHR system to actually have the image, at least not for this iteration of meaningful use objectives, but you are required to provide a link to that image. So in your database, you could simply have the radiology report come in as structured data, as it does for labs, but then you would need to provide a link that somebody who wants to look at the image can follow and look up. Can you speak a little more about having imaging available in EHR? I'm wondering if both of you are part of the same practice, because you've both asked very similar questions. So hopefully I've answered them for both of you. If you are a specialty and do not report on immunizations and also do not have reportable conditions, what is applicable? If you're a specialty and you do not report on immunizations, then obviously you wouldn't be able to meet that measure. And I'm not sure what kind of a specialty you might be where you would not have any reportable condition, but that is something that you would probably want to discuss with your local public health office. If a provider is on stage 2 this year, can they attest to stage 2 using 2011 edition? No, they cannot. So if this proposed rule goes through, if a provider was supposed to attest for stage 2 and they're still on a 2011 edition, they will need to attest for stage 1 using the 2013 criteria. Does email count as a medium to submit syndromic surveillance? No, it does not. It needs to be an interface. Oh, okay, I'm sorry. Then I think there's 2 of you who have exactly the same question around imaging, so hopefully I've answered that. If we're attesting for AIU right now, do we have to have the next-gen patient portal up this year to qualify our data for meaningful use to 2014 requirements? No. So AIU basically is for Medicaid attestation, and it is the first year that you're basically attesting that you have adopted an EHR system, or you've upgraded it for the first time. So this, you can't attest for AIU if you were already participating in the EHR program, the reimbursement program. So you do not need a portal for AIU. All right. Those were all the questions I had. Okay. I've been asked to wait, so I'll wait. When do you need to install the patient portal by? You need to install the patient portal by the year, in the year that you are going to be doing your Meaningful Use 1 attestation. And then that obviously assumes that you will have the portal in place by the time you get to stage 2. It seems from your messages that you are still in the very early stages of attestation. So if you were to attest for AIU this year, then yes, you would need to have your portal by 2015. How do we send patient reminders? So patient reminders, typically what practices do is they either have like a service like a teleminder or telebox, and then they basically link that to the patient reminder. Well, it depends on what EHR you're using, but there will be a section available where you are able to record information on what reminders might have been sent out. All right, let's see. Please look at CMS proposal, which clearly states that a provider can attest to stage 2 if they have not upgraded to 2014 edition can attest, I would really encourage you to, because I think I've talked about this a fair amount, I would encourage you to go back and read what the criteria is, but basically the 3 options that you have for attesting, I'll repeat them one more time. If the addition of your EHR is a 2011 edition only, your providers will need to attest for meaningful use 1 for the 2013 criteria, even if your providers would otherwise have been eligible to attest for meaningful use 2. There is no ambiguity on this. So you might want to go back and reread your source. Thanks, I'm glad you enjoyed it. Let's see. What actually generates them? So you're talking about patient reminders. These are generated from your calls, and then you will need to have some kind of software enhancement that allows you, or a workflow in place that allows you to take the patient's response to your reminders and update your EHR to say that you did actually send out this reminder. What generates it is probably some kind of a script that you might send to your to the service that you use, or if you have people calling your patients, then they would need to go and update your EHR. We're on the Medicaid track. Let's see. We're ready to attest for stage 2. We've already talked about that. For CPOE, do MAs need to be certified by state or just have graduated from a school? So this is an interesting question because it varies from state to state. But basically what CMS says is that any individual who is licensed to be able to make a clinical decision about drug allergy interaction can start a CPOE. However, the rendering provider needs to actually accept that CPOE. So 5.8 in KPM will not do the reminders without an external service. That is correct. There is, if you implement a portal, you could potentially use your portal to send out reminders. But other than that, 5.8 and 8.3 do not have any native capability to send out reminders. If they upgrade to 2014 edition, can they still do stage 1 requirements? Yeah, I think that is exactly what I was explaining earlier, that irrespective of what stage they're on, if providers are attesting on 2011 certified technology, they cannot attest for stage 2. They can only attest for stage 1. All right, I think that was all the questions. Thank you very much for participating, and next week we have actually, if you want to go back to to our website, there's a list of our upcoming webinars, so hopefully you'll be able to join us again. Thank you very much for participating. Bye-bye.